And thank you all for being here this morning with us to talk about the swallowing and voice disorders post-ACDF. So as Amelia said, I'm Elise and this is Cami. To start out, has anyone ever experienced a swallow study before? Anyone? Has anyone observed or seen a swallow study before? Wonderful. Of those of you who have seen a swallow study done before, do you know what the purpose of the swallow study was?
It was post-stroke.
Post-stroke?
So just seeing how their muscles are moving and if they're helping the food get down in the stomach so that they're not at risk for aspiration pneumonia.
Great. Yes, you covered a lot of really great areas there for us. As the swallow study is not just aspiration or no aspiration for us. We're looking at the anatomy, the physiology, looking at what is happening. Apparently my timer is on really short. My apologies. So here we are. Oops. On here, we're gonna observe this swallow study just quickly to get everyone familiar with the pace at which it's going. So not only looking for that aspiration or penetration into the trachea, but also looking at how the movement of the food is going down or the liquids or pills are moving down. Currently, we see a lot of different reasons why patients are coming in for us for swallow and voice disorders, but one of the main ones that we see often is post-ACDF. It's pretty much post-acutely surefire to have complications just due to the nature of where the surgery is and the movement of those muscles there. And so, when you guys are prepping for post-ACDF, is there anything that you're doing currently to prepare your patients for swallow and voice disorders post-surgery?
I usually try to educate them that they're going to have some inflammation just due to where we're working. They're being intubated, and I always say, like, you might want some soft foods for the first few days just to help with that.
Yes, that's great education to provide for them. The swallow is so passive that we often don't think about it when we do it all day, every day. But if you were to wake up post-surgery and not be able to swallow or have it be really painful to swallow, it could be really scary for a patient. So we really appreciate that you provide that education piece for them. While we were preparing for this presentation, we found a study that was done in 2017 about some tracheal retraction exercises or laryngeal massage, and it was that they would work on these muscles pre-operatively, provide some stretches for the patients to do. And what their findings were is that those who went through this pre-operatively, they had less occurrence of chronic dysphagia post-surgery. And so thinking of it from, I know some of you are more ortho-based, kind of that pre-PT versus post-PT, kind of prepping the body.
So these are some of the complications that can come from the surgery. A lot of these are nerve related. So you're probably not going to get a patient who comes in and says, so I think that there's something going on with my recurrent laryngeal nerve. Instead, they'll probably have specific symptoms that they'll complain of, like I'm having trouble with initiating my swallow, or it doesn't feel like it goes down all the way, or it feels like there's something stuck, or it just feels like there's always something there. Or it feels dry, or I'm clearing my throat all the time like that, or I'm coughing a lot, stuff goes down the wrong way. So they'll probably have more specific complaints than this, but these are some things that can happen from the surgery. And in addition to nerve injuries, a lot of it actually has to do with the edema and swelling, like you were talking about. Afterward, they just have a lot of swelling and inflammation, and some of that does have to do with intubation as well. And hematoma and bleeding can also contribute to some problems. So at what point, or what is it that a patient says about their swallow that makes you want to pursue it further for additional testing or maybe intervention?
I would say that it's the severity of the symptoms. So if someone's saying they can't eat or drink without, coughing or aspirating. That's a concern if they're not getting medications down.
Yeah.
And I think it's a timeline thing. And I'm actually curious to know on your guys' end, how long, because we have patients that complain of some mild dysphagia.
Yeah.
What is that timeline look like? How long should we expect? That's just a normal postoperative finding versus there's a more inherent concern. But going back, it would be the severity of the symptoms and how much it's affecting.
Yeah, I think that's why this is a good discussion point, because me and Elise talked about it also with our other speech therapist. What is the timeline for referring? But I think that a lot of it is just patient dependent, and it does have to do with, like you said, timeline. Is the patient getting better? What is the severity of their symptoms? Is there anything else? What are the symptoms exactly? And usually, because we expect some dysphagia immediately, then we just want to see how it's progressing. If it's getting better, then maybe it'll continue to get better. But if it's bad enough, or if it's kind of reached a plateau and it's not improving, then I think that's a good time to consider. But generally, we kind of decided 3 to 4 weeks might be a good guideline. But I really do feel like it's patient dependent. That's not a blanket statement. It's just at that point, okay, you really are having trouble. It's not just but at that point, hopefully the swelling's kind of gone down, and so there might be something there that is going to cause long-term problems. So.
And
that's kind of what we decided.
Yeah, it was a little varied on, specifics on what studies were considering as chronic versus not chronic. And so that timeline was very different. So some studies it was 1 month, some were 3 or 4. Generally speaking, we saw some indicators around that 4-week mark, like Cami was saying, to have some, if they're still having difficulties, to potentially seek additional treatment as well.
Is it safe to say we should have a low threshold then? I mean, if there's any concerns getting them to you early, I mean, is that advisable?
I think it kind of depends, but I one of the studies too said early screening and early detection of dysphagia is helpful, is better. So yeah, I think we have nothing wrong with. I kind of would prefer too if there was a lower threshold, just because then at that point at least they're getting something, especially if the patient's concerned about it and if they're stressed and if they're willing to do something about it, if they want intervention. I think that's something else to consider. But I mean, at the very least we can do some education and maybe give them a couple of tools and maybe a few exercises or something to kind of get it moving if it's, if they're not progressing like they expected. So I think it just depends on what you guys think and what the patient wants, and we're happy to see anyone who feels like they would benefit. So this is some of the current research that we came across. A lot of it had to do with identifying different risk factors and etiology. And as Elise was saying, a lot of the literature too was just pretty varied in how many people are experiencing dysphagia afterward. And I do think some of it had to do with how they were defining chronic. Was that some of it was after 1 month, some of it was after 3 months, it's considered chronic. But all the numbers were kind of anywhere between 9% of people experience dysphagia up to 70%. So it's kind of inconsistent and a little bit, there's just not much of a consensus there. But I think the main thing is it's safe to say that most people will have some trouble after swallowing after surgery. So just being able to provide that education and then just kind of seeing case by case what goes on. But how often do you guys feel like you're seeing patients who have serious concerns or chronic dysphagia?
As a home health nurse for some cervical patients, there's always, I think, a little bit of irritation in there.
Definitely.
And as we're assessing them, we have to decide whether or not it's just irritation or if it is actually a swallowing problem. I usually have them drink some water for me or something like that while we're there, just to see if there's any coughing or something going on. So I think it could be I mean, I think it's just a good assessment tool post-surgery, especially if they do have home health, just to see how each person is different and to address that at that time.
Yeah.
If needed.
Yeah, cool, awesome, yeah.
I think there's a lot of patients who don't know that they have dysphagia until you watch them take a pill and they tilt their head back like this.
Yeah.
And they say, I'm having a hard time swallowing. And like, that's not the appropriate way to take a pill because it's going to go the wrong place. So I think there's a lot of undiagnosed patients out there who don't know that there's a problem until they're in for
Yeah.
Say on the physical therapy side, you know, we're a little farther downstream sometimes than like inpatient and even home health. But it's useful, especially if the patient is like clearing their throat a lot, or if they, you know, I think one of the questions we'll ask them, like, is there any soreness? And I don't specifically ask about swallowing, but we do give them a bottle of water and we sort of watch that a bit.
Yeah.
But it's that hoarseness, and then, you know, they'll just sit just like a little bit and like, yeah. So that's just another question, and if it is, then we want to make sure we're doing a referral. But I think it's easy to miss on our end because we're so used to it. And on our side, it's like muscle stiffness and soreness, and we forget about the anterior side.
Right, yeah, and I think they're very related. But I think that's great that you guys are watching them swallow, because we have seen that nurses will do a bedside screen, and what it is you do 1 ounce and then 3 ounces, and that seems to be pretty sensitive. And so if you do see something going on, then at that point, I think it'd be good to follow up. What were you gonna say?
Based on that O'Connor study, should we have more preoperative referral to physical therapy just to reduce potential opioid use and then lower that NDI score, possibly? And then have you seen that preoperative referral to PT has improved, like significantly improved outcomes afterwards and less dysphagia and so on?
I think that's a really good point. We hadn't really thought about that as far as PT. We were thinking, how can we be involved, and if there is anything that we can do beforehand too as far as education or prepping. But I think that's great to get PTs involved as well, because a lot of times like it's just all related, and so it's good to just have different people looking at it with their different perspectives and just see if we can all help in some way. Like, yeah, I think that's a good idea. Okay. So these are some of the risk factors that were identified in a lot of different studies that we looked at. Things like if you're older, females are at a higher risk if you have diabetes. If it's in the upper cervical spine, or a lot of the studies too said like multi-levels. So just some different things to think about as far as the risk factors. What was I gonna say? Oh yeah. So this is a tool that we use. It's the EAT 10. So there's 10 different statements on here about swallowing, and like one of them is swallowing pills takes extra effort, and then you would rate that on a scale from 0, which is no problem, to 4, which is a severe problem. And we just kind of get an idea of what their symptoms are. If it's above a 3, then at that point we're kind of concerned, and it is pretty sensitive, so it should pick up on if anybody really is having trouble. If they get like a 2, then I've had it before where people will score kind of high, but it's really all just like swallowing is stressful, and then they don't really have much of a reason. But this is one of the tools. There's some different screeners that people use, but this one is the one that I've always used, and I like it because it's only 10 questions, so it's sensitive, so it doesn't take much time to go through with patients. But I think this would be a good one to do beforehand, and if they are having trouble swallowing already, then at that point we can be involved. But if after the surgery, give it again, and then we can see how that's changed and if it's gotten worse, and then maybe at that point get involved. So
Kind of thinking it like again around the 4-week kind of stage, so because immediately post-op, of course, they're going to be having those difficulties.
right, but your patients will do like a 4-week follow-up, right? Yeah. So I think at that point, this is a good time to just try it and see what they think. And I mean, they can even fill it out themselves. It doesn't have to be something you administer necessarily. Yeah. Okay, so when somebody is referred to me after like maybe 3 to 4 weeks or whatever it is, and they are still having chronic dysphagia, I like to, the first step is to start with an MBS so that we really know what's going on. And we can maybe identify where it's coming from and how severe it is, and if they are aspirating or if they're having trouble getting it down. Those are kind of the 2 main things we look at: safety, aspiration, and then efficiency. So then from there I can develop a plan of care, and we'll do oropharyngeal exercises depending on what's going on. I also will do laryngeal stretches and massage and reposturing. So like that technique that we learned at the beginning, I do that plus like different massage techniques. So also wanted to ask, just at what point are we comfortable with them moving, stretching, and with me massaging? Because I wouldn't do this right away, but later. Yeah, is there, yeah. Okay, cool. So when it is like that 3 to 4 weeks out, like it's probably okay to start doing that. Okay, yeah, but immediately if I get a consult for somebody who has just had surgery, it's acute, they're in the hospital, then at that point really what I do is more of just the education piece and giving them some strategies just to get by in the meantime, and hopefully get them through the problems that they are having. Another thing I wanted to mention, because we haven't talked about it really much yet, is the voice symptoms that they might have as well. So for the most part, we are concerned about the dysphagia because like it's a safety thing, it's a quality of life thing, and it's just usually a bigger complication. But sometimes people can have trouble with their voice as well. They have dysphonia. And so just something to kind of look out for, be aware of, and just notice if your patients are more hoarse than usual, if they're weak, or if they're telling you that their swallow is giving out, their voice is giving out by the end of the day, those kinds of things. If they're telling you any of those symptoms, or if you're noticing, then that's just something else that it could co-occur with the dysphagia, or it could just kind of be its own problem. Sometimes people just have more of one than the other. So another thing to look out for, and we do treatment for this as well. And these are our references.
So just wanting to, again, thank you guys for having us here today, but wanted to open the floor for discussion. I know swallowing voice isn't always something that is, top of mind for all of you guys, but so yeah, would love to open it up for you. Yes?
I loved hearing Lindsay's thought process on prevention and education in the beginning. I mean, I've had dozens of surgeries, and I remember waking up from surgery one time after being intubated, and I couldn't swallow, and I was like, what happened? And I had no idea that what intubation was, but I was like, what happened?
Right.
But if
Scary.
we had that conversation before about swallowing and how it can be an issue, like that would have put me at ease so much.
Yes.
And so much of what we do education-wise drastically decreases pain in general, right? If we just educate our patients ahead of time. The hardest part is being able to filter what's important and what's not, right? Because how much are they actually going to remember?
Yes.
But I do love when the providers just sit down prior to surgery and just talk it through. Like, what questions do you have? These are the things that you should be worried about. These are the things that you should be thinking about as you go forward.
Yes. It was so great to hear that preoperative education, because they were finding in the studies that patients had better positive mindset on the surgery, and kind of that hindsight, they felt better about the surgery if they had that education. And I think we all do better if we have that little bit of preparedness, right? If we know what's coming, we can anticipate it, versus waking up and not being able to swallow. So
Right, because at that point you're like, did something go horribly wrong? But no, that's just something that you can expect with intubation. Yeah.
My dad had swallowing issues. He had an accident, had to have a fusion, and was in rehab, had to have speech therapy actually for swallow. He was on a soft diet, and they had this machine that would make his food or make it look like the soft food, make it look like French toast or something. And it meant a lot to him just to be able to act like he was eating French toast. What has been your experience at just hearing, I guess, how much does it matter to people, and what have you heard in your experience from patients that have had restoration of some of that, what they lost? How does that impact them?
Yeah, I mean, I think it's hopefully very impactful. It's just a quality of life thing. If you can't eat, like, I think we just take it for granted. We don't realize that this is something that you could potentially have trouble with or lose. So yeah, once you're able to do more and get it back and you feel stronger. I had a patient yesterday telling me, this feels a lot stronger than it used to. And they're just not as concerned as they were, because before they'd be kind of scared to eat, like, am I gonna choke? And that's really scary. So yeah, I mean, I think usually by the time we're done with treatment, then they're saying, yeah, like everything feels better. I can actually eat what I want to. I've gone back to eating chips or whatever it is. Like, usually chips can be harder because they're just crumbly and dry. So yeah, I think it's been good.
You mentioned how efficacious your treatment is. Like, is there kind of a percentage of recovery that we can kind of anticipate, or I'm sure it's situational, but.
Yeah, that's a really good question. I mean, I feel like I've never had a patient who hasn't made any progress. But sometimes it's like, you're maybe not gonna get back to exactly what you had before, but you're gonna make a lot of progress. But usually with swallow, I do see pretty good results, just subjectively. Yeah, if people really do stick with their exercises and they're pretty dedicated, I've never had anybody who's not made any progress. Yeah.
If we were to standardize that E10 questionnaire at our first follow-up visit, is there a threshold that should trigger a referral for speech therapy on this score?
Anything, oh, there goes my voice. Anything over a 3.
Yeah. 3 and above?
3 and above, yeah.
So we could,
or greater than 3, sorry, so 4 and above.
So you're saying, like, if we were to just, like, today or tomorrow, next clinic, put that into our protocols, and if it's a post-anterior ACDF or arthroplasty, we screen, we probably should start screening before as well. Yeah. And then if they are a 4 or above, recommend an evaluation be done. Is that a reasonable protocol?
I think so. I mean, there was that discussion of, like, what are their symptoms, how severe is it, are they motivated, all of that. Does the patient want it? So I think, like, that can be considered, and it doesn't have to just be 3, but if that works to have it standardized, then I think that makes sense.
I think having a baseline would be good too. Because it might have been a 3 before surgery, and now it's a 4, versus somebody that was a 0 and now is a 6 or something.
Right.
But I think, we'll talk about that a little bit later. It seems like a pretty practical take-home dose.
That makes sense. And I think also, like, if they are having any trouble beforehand, or if they want to talk to us, like, we're happy to do consults. So, I mean, we're right here in the same building, so we can come in and talk to them, or a phone consult, they can call us. Yeah, I think we're happy to be involved at any step if we're wanted, if that's beneficial and necessary.
And that the E10, just of the score greater than 3, that gives us, you know, some idea of where they're at and maybe some justification to get them in for a modified, because no matter how great a screener is or a patient report questionnaire, no one can see what that swallow is truly looking like until we get them into the floral suite and can actually complete the imaging. So it's always a good first step.
I think just the reason it is so sensitive is because it's so low. Like, a 3 is pretty low. And so at that point, like, if they're having any concerns, then yeah, we can follow up. What were you gonna say?
Well, that was kind of into my next question is, I've never done a swallow study. I don't think a lot of people raise their hands that they're extremely familiar with how that goes. So I'm interested to hear more just about the experience of the swallow study. What is it I'm sending somebody to go do, and how does that function?
That's a really good question. Maybe we should have included more of that. It does taste bad. I get that feedback like almost every time. So we take them down to radiology, and so it's me and a radiologist. or a speech therapist and a radiologist. And we have a thin liquid that we give them, and we'll do a few different trials, like just with a teaspoon, and then with a straw, and then some sequential swallows. So we do that with thin, mildly thick, and then we have a pudding that we'll give them, and then we have like a cookie with some barium on it, so we can see a solid. it's really good. And then
If you ever want to ruin Luna Dunes, Lorna Dunes, come down.
and then we try, and then we just try a barium tablet so we can see what a pill might look like. So it's just those things, and then that's just from like a lateral view, and then I'll turn them and we'll do just a scan of their esophagus to see if that's actually where their symptoms are coming from, because sometimes it's more like dysmotility or something else going on esophageal, but they're experiencing symptoms here because our esophagus just isn't very sensitive to where it's having trouble. So we just do like a quick sweep, but I don't make a ton of like diagnoses as far as esophagus. It's just to kind of screen that. Yeah.
And then I guess to go next in line then, is that you guys typically that are managing and ordering those tests? And if we were to send an order, is it just to radiology? Do we send them with an order to you guys, or how does that go to get the study done?
Also a really good question, because a lot of times we'll get MBS referrals that are sent to Dry Creek, but it actually needs to be through the hospital. And since I'm contracted through the hospital, then I will still see them. Or yeah, it doesn't have to be here. But so sending it to the hospital and their scheduling team, then they can reach out to the patient and hopefully also reach out to me so that we can coordinate a time ideally. Yeah, did that answer your question? Okay, cool.
Yeah. Ultimately in the study, correct me if I'm wrong, but you're watching for the epiglottis to close, so that way the liquid or solids are not going into the airway, right?
Yeah, that's a really good question too. That is part of it. There's a lot of different components of the swallow, and sometimes it is like the epiglottis isn't retracting all the way. So that is one, but then sometimes it's like, are they getting good movement or is it limited range of motion? So we're looking at like anterior hyoid excursion. That's one of the things that we look at. Also just like overall laryngeal vestibular closure. Those are some of the main things that we look at as far as aspiration, but then we're also looking at like the posterior pharyngeal wall constriction, how well that movement is working, base of tongue retraction. It all kind of goes into making the swallow work. So that's where we go, okay, which component is it that's breaking down and why? And usually it has to do with weakness, or they're just not getting that range of motion for some reason. So sometimes that's tightness, which is why the massage can help too. But also usually if there's weakness, then we'll do that strengthening exercises too. So just looking at a lot of different components. Sorry, that was a lot of words that I was like, whoa.
Last question is, how important is the swallow study for what you're doing? Is that crucial for you to make a diagnosis and actually do what you're doing? Is that like a crucial piece of the puzzle?
The thing is, like, then we're just kind of treating symptoms, but I don't actually know what's happening. So it's kind of like if somebody's reporting stroke symptoms, but they haven't had any imaging for that, like an MRI or anything. And so it's like, yeah, we can tell that you're having aphasia, or we can tell that you're having dysarthria, but we just don't know exactly where the site is or how big it is. So it's that type of thing where it's like, we can see that there's trouble, you're telling us there's trouble, but sometimes patient symptoms aren't even totally the full picture. And so I think having that swallow study just helps me to have a lot more information about what exactly is going on and how I can help. So it's just good to have for that. Yeah. Okay.
Thank you all.